eu sou Fauze Maluf Filho, estou falando aqui de Campinas. Eu sou presidente da Comissão Científica da Sociedade Brasileira de Endoscopia Digestiva. Estamos falando do Centro de Convenções do Royal Palm Plaza, onde está ocorrendo o Simpósio Internacional da SOBED. E hoje nós temos o prazer de ter conosco o professor Kenneth Binmoeller, que é do Centro Pacífico de São Francisco, na Califórnia. O professor Kenneth Binmoeller é diretor da endoscopia de intervenção, endoscopia intervencionista daquele centro. So Ken, thank you so much for being with us. And Ken, you are a great professor. You are kind of guru for all of us in endoscopy. And I saw you attended DDW, that finished recently,
yes.
Right? It was in San Diego, correct?
Yes.
So you attended the conference. Which are the aspects or the new technologies that most impacted you during the conference? Could you comment on this, please?
Thank you, Fauze. You know, I think I can summarize it with two letters, A and I, artificial intelligence. I'm from San Francisco, and in San Francisco we are now seeing self-driving cars without drivers. And this is becoming very commonplace, and it certainly has made us aware of how artificial intelligence is already starting to enter into our world. And it's just that we don't want to think that it will also enter into the medical world. This DDW was proof that AI is entering into our space, in endoscopy especially. So we're seeing the use of AI programs. Right now it's still pattern recognition. So there are many abstracts demonstrating the value of computers that are able to recognize patterns and they can produce a diagnosis. So for example, if you have a polyp in the colon, the computer recognizes the pattern of that polyp and can say whether that polyp should be resected or not, and what the probability is that that polyp might be cancerous or have some cancer in it. So right now, the doctor is the one who is making that decision regarding the risk of cancer and whether it should be removed or not removed. That's what has required years and years of our training. Now, to think that a computer is able to make that decision, maybe even better than the doctor can, is a little bit frightening. So AI was all over DDW this year, and what we're going to be seeing in the future is it's going to go beyond the pattern recognition. It's actually going to give you the full algorithms in terms of how to treat the patient. And right now, it's just at the diagnostic level, but I'm sure it's going to enter the therapeutic level in the future, where we will have robots that can perform even the surgeries that we do, maybe better than we can do it. It already exists in surgery. There's Da Vinci robots, right? Yeah. Well, we're going to likely see the same type of evolution happening in our area of flexible endoscopy. So AI, it's something not to be ignored. It's here and it's here to stay, and we're going to be seeing much more of it in the future.
And thank you, Ken. Do you foresee that maybe in the future, technicians will be doing diagnostic endoscopy and doctors will be just supervising them?
Yes. You know, Fauze, I think you're right about this, because the role of the doctor as the operator was that the doctor's experience, having done all of these, let's say colonoscopy, okay? Having done so many thousands of colonoscopies, is able then to say which lesion should be resected, what the risk of cancer is, etc. If a computer can do that, then really the role of the operator is just to push the scope forward. And a technician could actually do that part, right? Doesn't need to have done the many thousands to learn the cognitive, the interpretation of the images. That's done by the computer. So the role of the technician would be more of just advancing the scope, and that is much easier to learn. So I think in the future, the training of the doctors will be different, because the doctors will not be the ones that are actually doing the endoscopy for diagnosis. Now, for therapy, there still is a role of the operator. So it could be that if the computer says this lesion should be removed, then the technician will call the doctor and the doctor will remove it. But I'm sure the day will come where the technician will call the robot and the robot will remove it, because maybe the robot can remove it better than the doctor can. Because the robot has many more degrees of freedom in the use of the tools. They have things called haptics where the sensors can tell exactly how much pressure there is, and many additional variables that can impact the outcome of the surgery. And this is why in surgery today, more and more of surgery is done robotically.
That's true. And last question. You were the inventor of luminal opposing stent,
Yes.
Axius. So what did you see on the use of Axius during DDW?
Well, that was for me the icing on the cake of DDW, because I invented this over a decade ago, and at the time that I invented it, the idea of creating an endoscopic anastomosis, so replacing the surgical anastomosis with a device that will reproduce what the surgical anastomosis does, it was science fiction. That was 10 years ago. Now we're seeing how this device is being applied for all of the indications for which, up till now, surgery was required. So now we're creating bypass procedures, gastroenterostomies, using the lumen-opposing metal stent. This allows us to do it with ultrasound guidance very quickly. And the results are looking that they are even better than a surgical anastomosis. So it's not even about avoiding surgery, which is more invasive, but actually having better outcomes than surgery. So we're taking the transluminal endoscopy, going across lumens into other structures outside of the GI tract. We're taking that to a new frontier, and this frontier is expanding. And at this year's DDW, we heard abstracts again about the gastroenterostomies, creating gastric bypass, but also creating biliary bypass procedures, gallbladder drainage. One abstract in particular caught my eye, which is a comparison of draining the gallbladder through the skin versus draining it from the inside using the lambs, and the results showed that the outcomes were far better when done from the inside, and the number of patients that required repeat procedures was significantly less if you did it from the inside. So we're seeing many examples of how a device enables us to do things we could not do before. So yes, it was for me, very gratifying seeing how a device that I invented over 10 years ago now is really seeing application into these new frontiers.
Thank you so much, and thank you once again having joined us in this conference.
My pleasure. Thank you.
Thank you. Muito bem, então dando continuidade à entrevista que eu fiz com o Dr. Binmoeller aqui do Simpósio Internacional da SOBED em Campinas, no Centro de Convenções do Royal Palm, resumindo, eu perguntei para ele quais foram as informações, as conferências que mais causaram impacto. E ele falou que, sem dúvida, inteligência artificial é a coisa que mais causou impacto nele. O quanto a inteligência artificial está entrando rapidamente dentro da nossa área da endoscopia. Ou seja, programas de computador incorporados a endoscópios que permitem não só a identificação da lesão, do pólipo, por exemplo, mas também a caracterização, dando um diagnóstico. Então ele prevê que num futuro, provavelmente técnicos poderão estar realizando exames endoscópicos e a máquina vai falar para o técnico se aquilo é um pólipo, se não é, se precisa ser removido ou não. E que aí o médico vai ser chamado apenas para remover o pólipo ou remover a lesão. E que num futuro mais distante ainda, talvez o técnico vai chamar o robô e o robô vai lá para fazer a ressecção. Logicamente isso num cenário muito futurista. Outra coisa que eu perguntei para ele foi sobre as próteses a posição de lumens, né? O LEMS, afinal ele foi o grande inventor, o criador da prótese a posição de lumens, que hoje comercialmente a gente conhece como Axius, é uma delas, e que está disponível no Brasil. Então ele comentou que ele ficou muito contente, ele criou isso há 10 anos e nesse DDW ele viu a ampla aplicação dessa prótese, criando anastomoses entre a via biliar e o trato digestório, entre a vesícula e o trato digestório, criando até anastomose próteses entre o estômago e o jejum, gastro-jejum anastomose e tantas outras aplicações. Então ele falou realmente ele sentiu gratificado de ver a utilização. E realmente, sem dúvida, com essas próteses você é capaz de criar verdadeiras anastomoses que antigamente só poderiam ser realizadas por cirurgiões. Então, pessoal, é isso aí, e no futuro vocês vão ter mais dessas entrevistas que a gente vai realizar para vocês aqui da Sobed. Obrigado e boa noite.